Good afternoon, everyone. It is noon, so we're going to go ahead and get started today. I would like to thank everyone for joining us on our webinar today. My name is Megan Collette, and I am a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. And we're welcoming you today to today's webinar, Cut to the Chase, Acute Pain Management and Opioid Use Disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send, and we'll address these questions as time permits during the Q&A portion at the end of our presentation. We are offering CME credit for today's webinar, and we'll have a slide up with information about obtaining these credits during the Q&A portion of our webinar. We will also email the continuing education credit information today after our webinar. The Overdose Prevention Engagement Network, or OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect physicians who are experts and specialize in prescribing medications for opioid use disorder and managing complex acute care and perioperative pain in the setting of OUD. They can also answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and/or MCBAP credits. And for our prescribers, all of our credits also qualify for the DEA-required SUD training. We provide MOUD training for physicians, and this year, we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services and more using the QR codes or by visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it the most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based, printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education support best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options as well. We assist groups across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We also fund implementation of naloxone vending machine and distribution boxes, naloxone administration training as well, and these trainings are offered as live, virtual, or free online courses. OPEN offers tried and true guidance for organizations interested in hosting a medication take-back event. The next take-back event is April 27th, which aligns with the DEA's National Take-Back Day. Visit our website to learn more about registering your event with the DEA and for advice on planning your event. Financial scholarships are available to those in financial need that are hosting events and high-impact counties listed on our site. Open understands that effectively addressing OUD and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of our state. We continue to provide regionally dedicated behavioral health consultants. Each work directly with physicians and physician groups and community organizations in your area are helped to build connections and networks locally. If you are already connected with the BHC in your area, wonderful. But if not, you'll be receiving a follow-up email from your dedicated BHC within the week. Please connect and utilize them to assist you in this important work. Now, I would like to get us started with our webinar today and would like to introduce Jillian. Jillian DiClemente is a pain management clinical pharmacist specialist at Michigan Medicine. She works with the pain, pharmacy service, and addiction consult team in the inpatient acute care setting. She is the coordinator for the pain management and palliative care residency program. In her role as chair of the Pain and Opioid Stewardship Subcommittee, she has coordinated efforts between several departments to capture baseline metrics pertaining to opioid and non-opioid analgesic medications in the inpatient and ambulatory care settings with ongoing monitoring and surveillance dashboards. Jillian also works with the Overdose Prevention Engagement Network to support, share, and provide expertise in education and research in pain management. And with that, Jillian, I would love to turn it over to you to get us started.
Thank you so much, Megan. I'm going to share my screen here. Thank you for that lovely introduction. Today, we're going to really dive into some of the nitty-gritty around pain management in patients with opioid use disorder. This, I'm going to bring to light some intriguing cases I think you may find fruitful, and hopefully you can relate them a little bit to your practice. I have no disclosures. This has been a planned activity with My Michigan Health. Please do what you need to do to get the credit for this presentation. And no one pays me to represent any of the medications that I'm talking about. And if I happen to mention brand names, I don't endorse any specific pharmaceutical company. I do want to have a warning. I have one slide with some graphic images, and I thought that it would just be respectful to all of you to include this warning that once we get to case 2, there's a little bit of a graphic image, and wanted to warn you in advance. And the learning objectives today, we're going to describe challenges of managing perioperative pain in patients with opioid use disorder, understand strategies for managing pain in these patients using cases, and then review considerations for initiation or continuation of MOUD, so medication for opioid use disorder, in perioperative patients with opioid use disorder. So let's jump into perioperative pain first, and then we're going to dive into the opioid use disorder side, and then we'll combine it all together with some cases. So first things first, perioperative pain looks different based on different procedures and how invasive it is, and how long the procedure is. I myself am a pharmacist. I'm not in the OR, and so it is not uncommon for me to be asking my colleagues, how invasive is this procedure, looking at the OR time, and how extensive the tissue disruption has been. It is very important when we're considering perioperative pain to consider the different etiologies or pain generators that are going into the patient's experience with pain. And so you may be familiar with these terms already, but nociceptive pain, neuropathic pain, mixed pain, and nociplastic pain. So these are different pain types that may be involved in the patient's experience with pain. And we'll dive into this a little bit more. This is one example I wanted to bring forward of total knee arthroplasty and some of the different experiences with pain that may contribute. So this includes as something as simple as the start of their IV during their perioperative period, the surgery itself, the pain that they experience from physical therapy afterward or wound care, just changing positions in the hospital or at home, anticipatory pain from previous surgery or experiences. So it is not uncommon for my patients, particularly with opioid use disorder, who have had unique experiences with pain in the past, to have anxiety and fear around managing pain after a new surgery or going into a new surgery. Infection can play a huge role into patients' experience with pain and the potential for scar tissue, especially upon repeat surgeries, right? So that scar tissue from previous surgeries can influence their experience with pain upon subsequent surgeries. And then for patients with baseline comorbidities that impact their pain, that includes, like for this patient, baseline osteoarthritis. So I talked a little bit about the different types of pain. I like to break them down. One of the reasons I like to break them down is because as a pharmacist, I'm very focused on, based on the mechanism of action of a medication, how is it helpful for different types of pain generators? So our nociceptive pain is our most prominent type of pain, I think, that we think about around the time of surgery. This can be somatic or visceral. And then our visceral pain is the experience is based on the type of mechanical, chemical, or thermal activity that happens at our nociceptors. And this can be the chemical activity that's going on can be from prostaglandins, serotonin, histamine, interleukin, substance P. Substance P is one of the ones I like to talk about when I'm thinking about one of our pain medications called capsaicin, and then TNF alpha. And so I think this is a nice little visual to kind of break down perioperative pain, but then we'll dive into the medications as well. It's important to highlight that unmanaged postoperative pain can come with unintended consequences. And so let's talk about one of those. Chronic pain is one of them. And we'll dive into a little bit of the statistics on our chronic post-surgical pain population. It's about 10% of all patients who get surgeries. Prolonged rehabilitation can lead to unmanaged postoperative pain, readmissions. So patients that are discharged on a pain regimen, maybe they're discharged home, their block wears off, their pain increases, they use the medications that have been prescribed, and then they end up back in the emergency department or reaching back out to the clinic. Medical complications, extended hospital stay is not uncommon. When I'm thinking about our patients with opioid use disorder, it's not uncommon for them to need larger quantities of opioids to appropriately manage pain in the immediate postoperative period, and the tapering of that can take some time. Transition to non-prescribed analgesia. So this is this is a risk that I just want to highlight. So when we do not appropriately and robustly manage pain in the postoperative period, patients who are abruptly discontinued from an opioid or not tapered appropriately or have unmanaged pain are very high risk for transitioning to non-prescribed medications or substances. Decreased quality of life. A lot of patients with unmanaged postoperative pain have a hard time participating in physical therapy, maybe due to pain, right? And so that poses a risk, and then leaving against medical advice. So if we are not keeping pain management at the forefront of our priority and managing pain after surgery, patients can have patient-directed discharges. There we go. So let's talk about this persistent surgical pain. So chronic persistent surgical pain, the exact mechanism is actually unknown. It's likely due to peripheral and central sensitization after persistent acute pain. So basically what that means is if someone has experienced acute pain and their peripheral nociceptive fibers are activated, and then they continue to be activated because of, could be complications from the surgery, could just be ongoing activation of these fibers. Then this process called sensitization occurs. And this is not talked about often enough, I think, in the pain world. I think it's important to actually talk to patients about this earlier, that if they experience chronic persistent pain, what that might lead to. But when we get sensitization of these fibers, that then leads to neuroplasticity, remodeling, and hyperactivity. So that pain that is normally painful is at a heightened painful response for someone who has experienced persistent pain over a duration of time. And there's lots of literature to support this. I point a few of them out here. Just keeping an eye on time. I might talk really fast, but that's because I'm excited to share all this information. I want to make sure I get through it. So chronic persistent surgical pain occurring at the site of incision or related areas for greater than 1 month or lasting longer than anticipated duration of healing. And it's challenging in managing acute postoperative pain while minimizing risk of persistent opioid use after surgery. And I put one table from this article published in The Lancet on the surgeries that have a higher prevalence of severe chronic post-surgical pain, and that includes knee arthroplasty, or some of our spine surgeries, inguinal hernia repair, and then thoracotomy. I think is a surgery we often associate with significant pain. So what does this have to do with opioid use disorder, right? So chronic post-surgical pain risk factors, there are many. I have not found any literature specifically looking at opioid use disorder in patients with chronic post-surgical pain and what that incidence is. But we can appreciate that there are subgroups with worse chronic post-surgical pain, and there's consistent evidence for this. So patients with more comorbidities, present pre-operative pain, stronger post-op pain intensity, greater fear or anxiety, and greater depression. And so one of the ones that I wanted to highlight here for you is this stronger post-operative pain intensity. So patients who have extraordinary exposure, it may not even be extraordinary, but persistent opioid exposure prior to a surgery, their experience of pain after surgery can be difficult to manage. And if they have high pain intensity, which is most of our patients with opioid use disorder, which is why we're very aggressive in treating their pain around the time of surgery, it makes sense that patients with opioid use fall into this population of patients with chronic post-surgical pain, or have a higher risk of chronic post-surgical pain because of their previous opioid exposure. So perioperative pain management is important. Multimodal analgesia, I know we've heard this many a time in many pain CEs that this is important. And then ERAS protocols are so early recovery or enhanced recovery after surgeries. A lot of these protocols started in the colorectal surgeries, and then other surgeries kind of have built on to these ERAS protocols with evidence based in their specific surgical field. And so all of these kind of protocols have optimized non-pharmacologic analgesia, so early movement, breathing, mindfulness. I won't go into all the details of this slide, but then there's regional local anesthesia, so customizing the local offerings that we can optimize for a patient. And so as someone who has worked with our, like in the acute pain service, anesthesia pain service, and with our addiction team, I'm very mindful of reaching out to the anesthesiologists who do these procedures, because any optimization of something that's not an opioid for our patients with opioid use disorder is tremendously helpful in reducing heightened pain response after surgery. And then systemic non-opioid analgesics, and then systemic opioid analgesics. So all of these, we want to use all of the things that are in our toolkit. I was unable to find anything specifically ERAS related and opioid use disorder, or any substance use disorder, really. This one here is actually, it was published in 2023 and it has been in process, but really highlights the importance of and the need for an ERAS protocol in patients with substance use disorders because of the heightened because of COVID's impact on patients with substance use disorder. And then there's an increasing rate of higher acuity surgical cases in the ambulatory setting, including patients with chronic pain and substance use disorder. So some of these procedures that were only done in more acute care settings are being expanded upon in our ambulatory surgical settings. And we need to equip these providers and these surgeons and these teams with the resources they need to manage more complex cases. So multimodal pain management, I will not go into every detail of this slide, but I wanted to put this in here because there are so many, and there's so many that are evidence-based now, and this is going to be unique to the patient's insurance. It's going to be unique to the allergies that the patient has, their patient-specific factors and what's available to them, their ability to participate in physical therapy, etc. And multimodal pain management for one patient may look very different than multimodal analgesia for another patient. But all of these should be considered and thought about, particularly for our patients in the treatment for opioid use disorder. So pain and opioid exposure, I want to highlight for you, tolerance does not mean dependence. And chronic opioid use does not necessarily mean opioid use disorder. So we need to start separating these out. Oftentimes there is a gray zone, right? Where patients have tolerance, where if, they were, they're not getting the same response to the opioid medication that they previously were, and they need escalating doses. Dependence becomes more of, if you were to miss a dose, do you start getting symptoms of opioid withdrawal? Chronic opioid use, some patients can be on an opioid for actually quite some time without developing dependence. And then opioid use disorder, that becomes more prevalent when we start asking questions about their compulsion, craving, consequences, and control. And so those are the 4 C's. Hyperalgesia and allodynia, I point out here because it is not uncommon for our patients with opioid use disorder who have significant exposure to synthetic opioids like fentanyl to have hyperalgesia. And so this is an increased response to noxious stimuli or allodynia. So perception of an ordinarily non-noxious stimulus, so something that's not usually painful, is actually painful to them. So a great example of this is when I go talk to a patient and just the bed sheet brushing up against their leg or their arm, it is painful for them. And so asking patients about things that are not normally painful, are they painful to them? And describing that they may have a heightened response to painful stimuli, and that opioids contribute to that process. Oops, sorry. So preoperative planning and expectation setting is important. Screening is important. I know I don't have time to go into the TAP screener, but this is an example of one that can be incorporated into your own clinical practices. Education of the patient and caregiver, and this expectation setting is so important. I know there is a lot of information shared with patients before surgery, and they can only retain so much information, but minimally helping them understand how often does it take for someone to heal after a surgery of this type or a procedure of this type, and the medications that will be used for the pain, and describing that there is no medication that can remove all pain. And so it would be unrealistic to expect no pain after a painful procedure. And making that very clear and having a good follow-up plan so that if pain becomes an issue or gets worse, what happens? So why is preoperative screening for opioid use or opioid exposure and other substances important before surgery? So this helps prompt conversations. It helps prepare for possible withdrawal management in getting appropriate teams involved, may allow time for pre-op opioid tapering. So is there optimization that can become or that can be done early before the surgery is planned? Connecting with controlled substance prescribers. So who manages their opioids right now? Is it an opioid treatment program or methadone clinic? Is it their primary care doctor? Is it a hematologist, et cetera? Anticipate consult to pain subspecialty services. And so emailing them. If there's not already a workflow within your institution or within your practice, finding out the best way to communicate and get individuals involved early so that they're aware before the consult is received, for example. Connecting patients to recovery medicine services before the surgery even happens, right? So that's always helpful. Preventing delays in discharge pertaining to disposition and difficult management of pain. And so if they need to go to a rehab afterwards, like a SAR or a skilled nursing facility, will they take this patient? Is there anticipated difficulty in identifying a facility for this patient because of certain complications, and how long will they be there? And who would be doing the follow-up for the opioids or pain management medications after that? So it did essentially just want to get across that early identification is important to start these conversations and to get the right individuals involved and to avoid unexpected cancellations. I can't do this presentation without highlighting the extraordinary amount of research evidence and resources that Open has for surgical opioid prescribing. They list the procedures and then the anticipated number of oxycodone tablets, for example. And then if you go onto the Open website, some of these have links with the detailed supporting evidence. And so this is a helpful resource to kind of understand what procedure did your patient have and what on average is an expected amount to be discharged on, and knowing that the literature that went into this in the research is not specific to patients with opioid use disorder, right? Or chronic opioid exposure prior to one of these surgeries. And so patients with opioid use disorder or chronic persistent opioid use prior to a surgery will not fit into these categories or these tablet quantities. So it's about 12:30. I want to at least get through one or two cases. And I'm happy to share these slides if Open allows for you to see the other cases as well. So let's dive into case number 1. This is an opioid use disorder with no MOUD, so no medication for opioid use disorder prior to admission, and acute pain. So let me tell you about this patient. And these patient examples come from my experience, my own practice, removing patient-specific factors that could be identifiable. And so these are real patient cases. This is a 38-year-old male with opioid use disorder, cocaine use disorder, insulin-dependent diabetes, left lower extremity foot wound. So this is not uncommon, right? We see this actually pretty frequently. Possible bipolar disorder, homelessness, and previous right by BKA, 1 year ago. He reports to the emergency department with a fever and was admitted for left lower extremity osteomyelitis and bacteremia, unfortunately. He states daily use of 1 to 1.5 grams of heroin or fentanyl last used yesterday. And daily use of cocaine. Reports he used previously on methadone during his last hospitalization for opioid use disorder, but returned to use due to transportation and mobility issues. He received 3 doses of 4 milligram IV push morphine in the previous 24 hours, and your reports pain is everywhere. It's not uncommon for our patients with significant opioid use disorder to have this hyperalgesia, allodynia, and opioid-induced hyperalgesia. The urine drug screen shows like a drug 6. It's just a screen, not a confirmatory test. Shows opioid, fentanyl, cocaine. Addiction medicine was consulted to assist with withdrawal management and substance use disorder planning, and below knee amputation is recommended, which the patient initially declined, but later agreed and received the BKA 10 days into the admission, actually. And so I like this slide because we're thinking about what are the medication for opioid use disorder options and the acute pain options. So is Suboxone an option for this patient? Is methadone? Our short-acting opioids is naltrexone. And how do we safely treat opioid use disorder and pain at the same time when there's an unclear surgical plan and an unclear dispo plan? So considerations that need to be taken place before any action planning is, what is the surgical plan? And consider the invasiveness of that procedure. What are the patient's goals? And what are their previous experiences with a medication for opioid use disorder? So like this patient had been on methadone before, had returned to use. And so is that a good option still for the patient? And considering timing of buprenorphine naloxone initiations and what that means. So we'll dive into that a little bit. Barriers to outpatient opioid treatment program follow-up options. So after a surgery, patients, depending on the severity of major versus minor surgery, they may not be able to physically go to a methadone clinic. And this is important because if they can't physically go to a methadone clinic every single day, that may not be a safe option for them or a feasible option for them, and would put them at increased risk for return to use. And then disposition, shelter versus recovery housing versus a skilled nursing facility. So this is going to influence decision-making around which MOUD may be best suited for this patient at this time. And risk mitigation is a full agonist versus partial agonist appropriate for the patient. We'll talk about that a little bit more. So before moving on to what we did with this patient, let's talk about the considerations. So this patient's going to have opioid use disorder and pain. And so if we were to do a medication for opioid use disorder for this patient, let's just review the prescribing requirements. So for methadone, opioid use disorder methadone for opioid use disorder can only be administered at a regulated opioid treatment program, but any provider can prescribe it for pain, as long as they have a valid DEA and controlled substance license. And it's a full agonist with high affinity for the mu opioid receptor. Suboxone is a partial agonist. It has extraordinarily high affinity for the mu opioid receptor. And in terms of prescribing, so any provider now with a valid DEA and controlled substance license and who have fulfilled the training requirement, which is that education, can prescribe Suboxone for opioid use disorder. For pain, any provider with a valid DEA and controlled substance license can prescribe a buprenorphine containing product for pain. Of note, while there are select buprenorphine products that are FDA approved for pain or for opioid use disorder, any of them can be used for both. And then naltrexone, so there are no prescribing restrictions on this medication. It's not a controlled substance, and it's an antagonist with also very high affinity for the mu opioid receptor. So let's talk about the pros and cons of each of these. And I won't go over every bullet point, but I'll try to highlight the important ones. So methadone routes of administration, there are several different routes of administration of methadone, which allows it to be a good option to continue or to start in the inpatient setting when certain routes of administration may be more or less available. So pros of methadone, less withdrawal symptoms because we can just start it or initiate it in the inpatient setting and can be slowly up titrated, can be continued with split dosing for acute pain. I'll explain that in just a minute. And then I wanted to highlight also methadone also is an NMDA receptor antagonist, which makes it very a nice analgesic for neuropathic type procedures or surgeries that have a more nerve-related injury. It can be tapered prior to discharge if needed, multiple routes of administration, and there has been some better outcomes for opioid use disorder than alternatives like naltrexone, for example. Cons may not suppress cravings until you get to 80 to 100 milligrams per day. And if we're starting at like 10 milligrams 3 times a day and increasing, they may not be able to get to doses that suppress cravings until much later in the admission. And so that's not always a feasible option because patients may be craving or return to use in the meantime. It takes time to reach steady state and there are tons of drug interactions and risk of QTC prolongation. And it's also illegal for PCPs to prescribe methadone for opioid use disorder. So they need to go to a clinic, which presents a logistical challenge. So it can require daily visits to the clinic, and there are transportation challenges oftentimes in this population. Pros of Suboxone, it does not require a daily trip to a clinic. Some prescribers offer virtual visits, can be prescribed by a PCP, and I think Open is a great advocate for supporting PCPs in this effort, and it can interrupt central sensitization from full agonist. So I have many a time transitioned patients actually to buprenorphine before surgery or even after surgery, and they report their pain is better. And so I think there is this misunderstanding around buprenorphine for pain, which is unfortunate, but I think we're coming around as a state of Michigan and across the nation in terms of appropriate use of buprenorphine. It has a better side effect profile, better safety profile, and it blocks the effects of non-prescribed opioids. So if for some reason their tolerance is decreased during the admission, if they were to return to use, they don't have as high of risk of overdose after discharge. And then cons, precipitated withdrawal could occur if it's initiated incorrectly. There's so much research out there for micro-initiations of buprenorphine. We do this all the time, and I think there's a lot more support for micro-initiations now where patients are not precipitated at all during the initiation, which is phenomenal, and they actually find their pain gets better because they have decreased opioid-induced hyperalgesia. It's not ideal to switch from full agonist to partial agonist in the acute perioperative setting. Likely transition post-op is more appropriate timing. It can be sometimes challenging to manage perioperative pain, but we have algorithms and protocols, and I'll share one of those with you if we have time. And then there's, yes, the warning for dental problems. So this was new added to the package insert. And so I encourage you to incorporate education into patients who are receiving buprenorphine or who you plan to initiate buprenorphine for appropriate dental care. And waiting an hour after brushing teeth or after taking a dose before you brush your teeth, because it can disrupt the enamel on teeth. And then you need a prescriber for buprenorphine naloxone. While there are more and more across the state of Michigan, we need way more. And naltrexone, so the pros of this one, it's an IM injection every 4 weeks, can be more convenient, may not suppress cravings, and there's no withdrawal if it's abruptly discontinued. It's not a controlled substance. PCPs may be more comfortable prescribing this because it's not a controlled substance, and there may be less stigma around it because it's not a medication you're taking daily, and maybe a treatment option for certain healthcare professions or professions who are looking for treatment, or professions who cannot be on an opioid medication as a treatment option. So I'm talking about people who drive vehicles, for example. And then cons does not help for opioid dependent pain. It's not helpful for pain. And then oral formulation non-adherence. So if you're on the oral formulation before the IM injection, it really relies on the patient to be taking this regularly. You must hold full agonist therapy for a week or more prior to initiating naltrexone. And so there's increased risk of precipitation if they were to start it too soon after a surgery, for example, when they received an opioid for the surgery. And it's kind of unrealistic if future surgical procedures are in the picture because of managing pain around the time of surgery. Naltrexone binds so tight to the mu opioid receptor that if you add opioids on top of the naltrexone, that's not really going to do anything for pain management. It makes it very challenging to manage pain with opioids. You really have to inundate the receptor with full agonist. And then it needs a prescriber monitoring of liver enzymes, of course. Okay, I'm gonna jump forward into what we did for this patient and then kind of conclude the slides, but I'm happy to share the additional cases with you. And I'm sorry we didn't have more time to go through them. So preoperatively, we did for this patient for case number 1, we did aggressive pain and opioid withdrawal management. We initially started methadone 10 milligrams 3 times a day plus a high dose PCA, and then transitioned to a PCA. And then to oral hydromorphone prior to surgery. We were able to coordinate with the perioperative team to do a saphenous and a popliteal block. And then immediate post-op, we ended up increasing the methadone and having a hydromorphone PCA. The acute pain service was consulted, and the patient actually declined ketamine infusion for pain management. I think we find most patients really are liking ketamine for pain management, particularly when they're opioid tolerant, but this patient did not want to try it. And then over 72 hours post-op, after they're over that kind of hump of very acute post-op pain, we continued methadone and transitioned to hydromorphone, the hydromorphone PCA to an opioid rotation to oxycodone. And greater than 1 week out, the patient was still admitted, and we actually ended up transitioning the methadone to Suboxone for opioid use disorder to accommodate some of the discharge logistics into a recuperative care medical respite program. So supportive and non-opioid analgesic medications that were used were acetaminophen, IV ketorolac, methocarbamol, gabapentin, clonidine, hydroxyzine, loperamide, and prochlorperazine. And so initially Suboxone was not on the plan for this patient, and it was a transition later based on outpatient feasibility and logistics of this patient getting to clinic every day was just not an option. So it was good to use the methadone initially. I think it was helpful for the pain management and for the transition from high dose non-prescribed opioids to something that could be feasibly used in the inpatient setting, and then using short-acting opioids in addition to that, and then setting the patient up for success in terms of transitioning to something that can continue and support their recovery, which was the Suboxone after discharge. Naltrexone was not an option because of the surgical planning, the patient's goals, and also some of the more patient-specific logistics. So if my takeaway for managing pain in patients with opioid use disorder is to be aggressive in your acute pain management. The patient already has an opioid use disorder. By giving them an opioid, you're not going to make their opioid use disorder worse. You're going to allow them to treat or at least meet their opioid requirements so they stay for the care that they need, which is really important. Okay, I'm going to, sorry about this, skip forward actually to some of our concluding slides, so I leave enough time for questions, and happy to share these with you moving forward. As I said before, so MOUD initiation in the era of fentanyl. Fentanyl is a synthetic full opioid receptor antagonist. It's lipophilic with highly variable clearance. And because it is very lipophilic, when patients say their last use was yesterday, they're not going to reach the height of opioid withdrawal for about 48 to 72 hours and sometimes longer, depending on how much they're using and like what their BMI is, et cetera. And so it's, back when heroin was really our kind of our concern, patients would hit a peak of opioid withdrawal within about 12 hours, in 12 to 24 hours. And that is very different than practice now. And we have to really anticipate the peak of the withdrawal and asking patients when their last use was and testing for fentanyl. Negatively impacting initiation of MOUD, yes. So patients who are prematurely or started on Suboxone or buprenorphine too early and precipitate really severe withdrawal, those patients have had such a bad experience with the buprenorphine, they may not be open to buprenorphine in the future for opioid use disorder or pain. And so it's really important to understand the timing of buprenorphine initiation and to do that very thoughtfully to avoid any precipitated withdrawal. Clinical pearls, so opioid use disorder, dosing of methadone and buprenorphine are very different than pain dosing. And I just really want to highlight that. Disposition planning is imperative, and that should always be at the forefront for our acute care patients and even for our ambulatory patients who are planning for the future. Opioid withdrawal, urges and cravings, and undertreated pain are risk factors for patients leaving against medical advice. And so this is why we need to be very aggressive in treating their pain quickly and treating their urges and cravings quickly so that they stay for the care that they need. And then patients injecting fentanyl have very high opioid tolerance and may not respond to opioids at any dose. So it's not unreasonable to have the conversation with the patient of, as we escalate opioids and your pain is not getting better, maybe your pain is not opioid responsive. So let's optimize some of these non-opioid analgesics. Multimodal pain treatment is crucial for the management of opioid tolerant patients, and treating withdrawal does not necessarily suppress urges and cravings to use. So even though we're meeting their baseline opioid requirements, if they're not in significant withdrawal, it does not mean that they're not still craving or having urges to use. And must carefully balance the preoperative opioid dosing minimization with pain and withdrawal management. So the opioid exposure prior to procedures. So summary and recommendations. I know I didn't get to go through all the cases, and I think that's okay, but set expectations with the patient around pain and plan ahead. Consult subspecialties if those are available in your area. Continue a medication for opioid use disorder. Do not stop methadone or buprenorphine before surgery. We continue these and modify the dosing around the time of surgery. Be aggressive in treating pain and expect that patients with the opioid tolerance need higher doses of opioids after surgery than someone who does not have the opioid exposure. And transitions of care should always be at the forefront of how we're thinking about managing patients with opioid use disorder and what options are available to them and feasible to them after surgery. Okay, I'm gonna pause there. The second case I had was we have methadone. We also have one on buprenorphine. So if we have questions, I can also bring back some of the slides that we didn't get to. And I apologize for that. It's a lot of content to cover.
We appreciate it so much, Jillian. Thank you so much for this wonderful presentation. We are just glad to have you here and appreciate your time. We are going to get to our questions in just a moment, but if you'll notice, the continuing education credit information is there on your screen. You can either scan that QR code just using your phone or whatever electronic you have, or click the links below to access that information to obtain these credits. And we'll also be emailing this to you all as attendees today. So now to get to our Q&A, we do have a few that came in for you, Jillian. So we'll kind of go through these and for whatever our time allows here in the next 7 or 8 minutes. So the first question is CPSP caused and or exacerbated by initial poor pain management?
I saw that question. Thank you, Kate. So chronic post-surgical pain can put yes, so poor pain management initially can cause additional firing of the nerve fibers, and that persistent firing leads to increased risk of chronic post-surgical pain. So yes, that's also why I'm so passionate about saying be aggressive in treating pain, because if we don't treat it early and kind of stay on top of it, it can put patients at risk for chronic post-surgical pain.
Great. And then is tapering recommended of opioids prior to surgery when possible?
Yes, this is always weighing the risks and the benefits, and specifically in patients with opioid use disorder, tapering opioids prior to surgery may not be feasible. And that's because of risk of return to use, which can also increase risk of infection prior to surgery. And so patients who are on stable dose of their medication for opioid use disorder, I do not recommend tapering. It's more patients who have chronic persistent opioid use, but not opioid use disorder, that I think it's appropriate to talk to the patient about decreasing their exposure and presenting it as even minuscule decreases in opioids prior to surgery can help you have a better experience with pain after surgery.
Great, thanks. What is the best practice for documentation for patients in recovery for SUD to make sure we convey this information and their preferences across teams? Should this be noted as an allergy?
This is really interesting, and I don't know if I have the best answer or know what all of our different institutions are doing around how these flags are presented. One of the things I find helpful is not necessarily an allergy, but if your institution allows a flag for controlled substances and then inputting in there a little bit more information about what has worked well for the patient for pain management. I hope that answers the question. I think I am very cautious about the way I word things in the electronic medical record because I don't want to further stigmatize the patient. So we are very thoughtful about when we use the term opioid use disorder or substance use disorder if it has not been formally diagnosed, and trying to use more terms of like patient does not identify with having an opioid use disorder or patient has significant opioid tolerance, and using terminology to support to support them in a way that does not further stigmatize them or create a situation in which they may be stigmatized in the future. So we're always very thoughtful about how we're documenting. So I appreciate this question so much. And I don't know if I have a great answer for you, but I think exploring what flags are available can be one step. And one example of something I've done is when I've had a patient on Suboxone for opioid use disorder, who comes to the hospital for repeat procedures or has multiple surgeries planned, in that flag describing that which teams have been involved in their care previously and what has worked well for their pain. And in some patients, I even go to the extent of saying, instead of doing, 24 hours of IV push, let's start a PCA at this dose. They've tolerated it before if they have the same level of opioid exposure that prior to their next admission. And so kind of giving those details if possible.
Great.
I hope that answered that question.
I think it's great. Do you have a favorite reference for assisting with micro initiation?
Yes, me. So I consult for open and always happy to give um even further talks on micro initiations. We do so many and I do this almost every day and we've had such success. Um in terms of I can maybe I can share with Sarah or open some of the pieces of literature that are good for micro initiations. But what it comes down to is what is on your formulary at your hospital or within your health system, what is covered by the patient's insurance, and at what oral morphine equivalent are they starting at before during this initiation. So I think there's such nuance into micro initiation. Some are more straightforward than others. And sometimes I think what's in the literature is hard to apply to your own practice, which is nice to talk to someone who does this often, right? Yes, thanks. I got a note about the Bernice method is also yes, I can share that method as well in terms of micro initiation. So sorry, I don't have one specific resource that's like, this has all of the different ways we do micro initiation, but recommending and not hesitating to reach out if you have specific patient examples that you want to share with us and that we can help you work through.
Awesome. We have time for one more. It says, can you share your ketamine infusion protocol in opioid dependent patients in the post-op period and references?
Yes, I would love to do that. We use so much ketamine, and I know some institutions have that as an analgesic, and some don't. And so always happy to share that as a follow-up. Yeah.
Wonderful. Well, with that, we here at Open just want to thank you so much for being with us, Jillian, and thank you to everyone else for joining us for our webinar today. And we hope that we'll see you at future events hosted by Open. And we hope everyone has a wonderful afternoon. Thank you so much to everyone.